I'm John Hesla. I'm the medical director of Oregon Reproductive Medicine. We're a large fertility clinic in Portland, and we help men and women throughout the world have children through egg donation and surrogacy. So I'm really pleased you could come here today to allow me to provide you with some information about what makes our program unique. For many years, we've supported gay family building through egg donation and surrogacy. And we're very proud to be a sponsor of Men Having Babies. We participate in all of the sessions, actually, that Men Having Babies hosts. And we're proud to offer an unlimited number of the GPAP Stage 1 awards in 2017. So if any of you are considering applying, I'd recommend that you apply as soon as you can. Just to provide you with some information about me, I'm a graduate of Harvard. I received my bachelor's degree with honors in biochemistry, and I completed my medical training at UCLA and at Johns Hopkins. And when I finished my fellowship in fertility at Johns Hopkins, I became a professor there. And for several years, I was the director of the IVF program at Hopkins. And then I also worked at Emory University, where I founded the IVF program. In 1999, I moved to Portland, which is my home city, and I helped found the IVF program at Oregon Reproductive Medicine. I am a member of the Men Having Babies Advisory Circle, and I'm also the medical director of an internet-based international support group for men and women who are becoming parents or who are parents through egg donation, and that organization is called Parents Via Egg Donation. Our clinic is located in the Central Business District of Portland. This is our new facility. We opened it in 2015. It's really a state-of-the-art facility. We hired engineers who are involved in constructing the fabrication plants at Intel to help design and construct our laboratory, because we know that embryos are very sensitive to pollution and environmental factors, and we wanted to provide the very best technology to allow embryos to grow as well as possible in the lab. Because you have to understand that the first 5 or 6 days of your baby's life, your child's life, will take place in the laboratory. So that's a very critical time period for development. And if there are any abnormalities or perturbations in the environment, it will affect the development of the embryo, it will affect the pregnancy rate, and it could potentially even have an adverse effect on the health of the baby. Our clinic this year will perform about 300 egg donor surrogacy cycles, and that makes us one of the top clinics in the country in terms of the number of surrogacy treatments that we provide. So this is one of our specialties. We've been working with surrogacy agencies and parents for many, many years, so we're experienced in the importance of good communication and good coordination of treatments. I'm also proud to say that our clinic has consistently had high pregnancy rates for many years, and that's one of the reasons why we help couples from over 40 countries who come to Portland, Oregon, little Portland, for their medical care. But our goal has always been to try to take any step possible to adapt new technology to patient care, to try to increase the odds that a family will occur from one treatment. Because there's nothing more sad and disappointing than a negative treatment cycle. So we really want to give everyone the best chance for success, and that's what our focus has been since we opened our clinic, our laboratory, in 1999. Another great thing about our clinic is it is in Oregon. It's a wonderful state. It's a very good state in terms of its policies for surrogacy and its laws regarding surrogacy. Also, interestingly, Oregon has the lowest rate of preterm labor in the United States. So women who are pregnant in Oregon are more likely to deliver close to their due date, which is, of course, important for the health of the baby. We have wonderful surrogacy agencies in the West, but interestingly, a lot of the agencies that are in the East also recruit surrogates in the West. So even if you worked with a local agency here, they might have a surrogate they could offer you who lives relatively close to our clinic. But surrogates will fly from Canada and other states in the United States to our clinic for their embryo transfer. They don't have to spend very much time in Portland, so it's not very expensive for their travel costs. Our clinic has its own egg donor program, and we have healthy donors who are willing to have contact with future parents, future fathers. I think in the West there's been more of a degree of openness of interaction between donors and parents, donors and fathers, as compared to other regions of the United States. Although certainly I think that there's a greater openness throughout the country now. So it's become quite common for parents to have some sort of relationship, ongoing relationship with their egg donor. Portland's a great place to visit. We have wonderful restaurants, great coffee, wine. It's a fun place to come for a long weekend. This is actually the lobby of the hotel that's right across the street from our building. So we have great hotels that are right next door. And it's a great place too to visit in terms of the scenic beauty. The Oregon coast is spectacular, and it's only about an hour from our clinic. And there's no sales tax in Oregon, so a lot of our international patients especially like to buy certain products like Louis Vuitton when they come to Portland. But we're proud of our experience in surrogacy, and we're proud of our high success. There's different ways of trying to analyze the success rates that clinics have, because unfortunately we all tend to be very optimistic when we're quoting statistics. So one way of looking at success rates and comparing them is this website called fertilitysuccessrates.com. It does list the published data regarding pregnancies and live birth rates through egg donation. And then another place you can find the live birth rates is by looking at the CDC website. The US government every year will publish a report that indicates the live birth rates of different types of fertility treatments nationally, as well as within individual clinics. So all of the clinics are required to report their data to the government, and it's listed on the CDC. You won't necessarily be able to identify egg donor surrogacy cycles. They'll just give you information regarding egg donor cycles. So you can kind of compare one clinic to another. Because really, all clinics try to treat egg donors in the best way they can. So if there's a difference in pregnancy rates, it's probably related to the laboratory, because the laboratory is very important for the success rate. So if you want to get some idea in terms of what the variance might be among clinics that you're considering, you can look at the CDC website. Just Google CDC ART, and you'll find the information. Our clinic is a team of about 125 people. We have 7 full-time physicians and 1 part-time physician. We also have an integrative medicine specialist who does consultations, which is not common. And we are one of the few clinics that has a very strong genetic counselor team. So we have 4 genetic counselors who are devoted to analyzing the genetic risks of you and your egg donor to make sure that you pick the right egg donor so that you have a very low chance of having a baby that has health problems in the future. We have a team of egg donor surrogacy coordinators who would work with you. You'd be assigned a single coordinator and a single physician who would guide you throughout the entire process of treating both your egg donor and your surrogate. So we really aim to provide personalized care, and we honor open communication. We communicate regularly with our patients by phone, by Skype, by text messages, although mostly we use email. Oregon Reproductive Medicine has its own egg donor program. Patients are not required to use our egg donors, although I would say about 80% of the patients that we help, of the future parents that we help, will pick a donor through our donor database. We recruit and screen egg donors every day. We have generally about 150 donors who will be treated during an entire year. But some of them will go through treatments more than once, so the total number of treatment cycles would be higher than this. All of the egg donors that are available for selection through our clinic have completed their medical testing, so we know they qualify. We've evaluated their ovaries. We've screened them for infectious diseases. They've had a psychological assessment through our psychologist. They've completed psychological testing through multiple choice test. And we've done drug screens and infectious disease on them. So we know that they qualify. Some women who apply to be donors don't qualify, and some women choose not to donate because it's quite a bit of work. So we ultimately accept only about 7% of women who initially express some interest in being a donor. Our donor team knows our donors, so if you have any questions that you want to ask the team about our donors, you can, and we can certainly pass on that question to the donor to get additional information for you. Our profiles, our donor biographies, are about 25 pages long. So we ask the donor extensive information about her medical background, the medical background of her family members for 3 generations, as well as information about her education, her career, her outside interests, her talents, her hobbies, her aspirations in life. Because that's important information for you. You're making a very important choice. You're picking someone who's going to be providing half the DNA of your child. So our goal is to help you make an informed decision so that you are making the right choice for your family. One of the nice things that our genetic counselors will do is they'll create this genetic assessment, which we call the GIFT, which is Genetic Information and Family Tree. And you'll be able to receive a copy of that to know what the genetic counselor has assessed regarding the risk of health problems if you were to select that donor. And then, of course, you can see pictures of donors. You can learn about their medical testing, the number of egg cysts or follicles that they have, which predicts the number of eggs that they might make. And we also do a blood test on them to measure a hormone called AMH that also gives us information regarding the number of eggs that they may have. If the donors donated in the past, we'll provide you with information about the outcome of the past donations. And that can be especially helpful for male couples where both men are providing sperm, because if we're working with 2 sperm providers, we want to have at least 20 eggs in order to give the couple the best chance that both men will have embryos to use in the future.
What genetic test do you do? You said there's an extensive genetic testing.
The genetic test that we do to screen the donor is usually through a company called Counsel, which screens for 175 autosomal recessive and X-linked recessive diseases. We have a program that we call ORM Surrogacy that really reflects our philosophy towards working with surrogates and surrogacy agencies. We have very strong collaborations with the surrogacy agencies. We work closely with them in completing the screening of the surrogate to make sure that they're appropriate candidates to carry a pregnancy for another couple. Most of the surrogates that we work with are helping either single men or gay male couples. Our clinic is very glad to collaborate with whatever surrogacy agency you want to work with. We'd be happy to work with any of the agencies that are present at today's meeting. The cost is generally less, though, if you find a surrogate that's close to our clinic, because then the surrogate would not have to travel to our clinic for their embryo transfer. But we are very careful with our selection process because we know that the woman's past obstetrical history predicts whether or not she would be at higher risk for complications in a future pregnancy. So one of the important screening processes that we do is we obtain and review all the medical records of past pregnancies and past deliveries to ensure that there's no red flags, no abnormalities in those records that might place the surrogate at higher risk for complications. We always look closer at the background, the medical background of a surrogate who might be carrying twins, because twins are definitely a higher risk pregnancy even for surrogates. And there are some parents that we help who really would like twins. So for those treatments, we are very, very strict in terms of what criteria will allow for a surrogate to move forward with transferring two embryos. Another component of our medical care is genomics, which is genetic assessment of the man and the egg donor before the treatment, and then potential genetic assessment of the embryos after they've been created. So we focus on the family medical history of both the future fathers and the egg donor, looking to see if there are any clues that the combination of the DNA of the man and the egg donor might increase the odds of health problems in a child either early in life or perhaps even later in life. We do genetic screening of egg donors and intended parents. This is the council test that you had asked about, where we screen for 175 relatively rare genetic diseases to determine if the man and the woman are carrying the same mutation for the exact same disease. And if they are, then we can't move forward with the man selecting that donor. He would need to select a different donor. So all that's done before we finalize the selection of the egg donor. But there's also the potential of analyzing the embryo after it's been created. So we can biopsy the embryo to test its chromosomes for an abnormal number of chromosomes. We can also test the embryo to see if there's a small mutation that could lead to a genetic disease. And that sort of screening is called PGD, where we're screening for a disease like cystic fibrosis or muscular dystrophy, whereas you'll hear clinics refer to genetic testing for PGS, which is pre-implantation genetic screening, or CCS. That's testing the number of chromosomes in the cells, testing to see if the embryo has 46 chromosomes in each cell or a different number of chromosomes.
Do you ever do both?
Yes, we do both. So I'll give you an example. There's a patient I'm treating now, a woman who lives in Uruguay. She has Marfan syndrome, which is a genetic disease. Half of her eggs will have Marfan syndrome if they lead to children, but half will not. So she's going through IVF. We're creating her embryos. The woman is 38, so she's older as well. So we're biopsying her embryos to test the number of chromosomes, which unfortunately, as women get older, the rate of genetic abnormalities increases in embryos based on the number of chromosomes. But we're also testing her embryos for Marfan syndrome. And so the embryos will be tested for 2 genetic problems. She actually already has a child through our program from one of the embryos that have been biopsied twice for these 2 conditions. And because she has Marfan syndrome, she's using a surrogate because she has a heart problem with Marfan syndrome where it would place her at high risk to carry a pregnancy. So not all of our surrogacy cases are for gay men. We do help women as well. But anyway, getting back to this, if we biopsy the embryo, we can remove about 4 or 5 cells from the embryo when it's starting to hatch. So this occurs when the embryo is either 5 or 6 days old. And when we do this, the testing of the cells that we removed, and again, these are placental cells that we've taken off. Yes, so We do not have to do PGD. We do not have to test for diseases like cystic fibrosis or Marfan syndrome or other genetic diseases where there's a very small mutation. But any man and any woman in the world together can make an embryo with an abnormal number of chromosomes. And so the Council test doesn't predict what percentage of embryos will have an abnormal number of chromosomes. We can only determine that by testing the cells of the embryo before we put it into the surrogate's uterus, or by having the fetus tested after the woman is pregnant, where perhaps the pregnant woman can have an amniocentesis to test the cells when she's 14 or 16 weeks pregnant. So let me just move ahead because I think that we're running out of time. These are our live birth rates for our program in 2015. So of course the results are influenced by whether we place one embryo or two embryos into the uterus. When we place two embryos in the uterus, the pregnancy rate is much higher, but the twin rate is also very high. So we really only recommend placing one embryo at a time unless someone truly wants to have twins. We have a pricing plan where it doesn't really cost more to do single embryo transfers until you achieve a pregnancy as compared to if you put in two at a time. So we don't necessarily want to encourage people to try for twins just because this rate is a lot higher than this rate. So this is data from the CDC. Again, if you look at the CDC website, this is what you're going to see. If you look at,
Is that with egg donors?
this is with egg donors. If we look at the SART database, which is a different database on the internet, this is our live birth rate for donor egg cycles, transferring one or two embryos as compared to the national average for transferring one or two embryos. So again, I'm proud to inform you that we have a very strong program in terms of success rates. One patient asked me earlier today what our live birth rate has been over many years. So I have this table to show the Oregon Reproductive Medicine live birth rates in treatment cycles from 2000 to 2014. So this is over a 14-year period. And in egg donor cycles, which is this bar, our live birth rate over this 14-year period using non-biopsied embryos in this circumstance was 75%, whereas the national average in 2013 for donor egg cycles, the live birth rate was 55%.
Is that with one embryo transfer?
This is with one or two embryos. Again, a lot of this data is older, and 10 years ago, 15 years ago, most people transferred one embryo. So it's only really been in the past 8 years, I would say, that we've been focusing on transferring one embryo. If I said one before, I meant two. So historically, we transferred two embryos. I remember back at Johns Hopkins when I was working there in 1990, we would transfer 3 or 4 embryos because the pregnancy rate was so much lower back then. There's been a lot of advances over the past 30 years in these treatments. But just to close, I want to make this statement that we consider egg donors and surrogates our patients, just as we consider future parents our patients. And we're really proud of our team, and we're really, really grateful to our egg donors and surrogates who help create families for couples all throughout the United States and in many different countries. So thanks very much for coming to my breakout session today. I'd be very glad to talk to any of you by Skype or in person actually later today. And we'd certainly be glad to see you in Portland. Thank you.